Alright, so this is part 4 of musculoskeletal conditions, and we're going to talk about fractures very briefly. Certainly when you're looking at conditions such as osteogenesis imperfecta, fractures play a part into that. I only combined it with the scoliosis just because the two PowerPoints aren't quite as long, so they sort of fit together here and made uploading a little bit easier. So looking at fractures, fractures are known to be very common in children, and if you think of children's lifestyles and activities and playing, it's not uncommon, right? Children get in bicycle accidents, they fall off their bike and they break a leg, or they break an arm, or they're jumping on beds and they fall off and they break their arm, or a finger, skateboarding, all of those very active types of things kids do. They get into little accidents and they may have a fracture. Climbing trees, falling out of the trees. I mean, the sky's the limit. Even playing different sports, right? Football, basketball. I remember going to the state track meet in high school, and there was a girl running the 300-meter hurdles, and she got her foot caught on one of the hurdles and fell, and you just heard a snap, and her bone ended up sticking out of her leg, and everybody gasped, and it was very dramatic and very sad. But yes, fractures happen. They're very uncommon in typically developing infants because those bones are still becoming hard, right? And so a lot of times with your typically developing infants, there's a little bit more give and the bones aren't as solidified yet. Usually a high number of fractures in a child can signal some type of child abuse, or again, as what we've mentioned before, it could signify osteogenesis imperfecta as well, or a certain type of condition similar to that. So when we look at the different types of classifications of fractures, you have an open or compound fracture, it's sometimes called. And this is where the bone angles and actually comes through the skin. So it actually opens and comes through the skin. So there's some significant soft tissue damage also, since that skin is being broken, and then it's open for infection to set in. So you can see here, this would be an x-ray of an open or compound fracture. You can kind of see the edge of the skin here, which is open. So those can get very, very ugly. And you can see here it's broken all the way to her tibia and fibula, or tibia and fibula. The next type of classification is called a closed fracture. Closed fracture just simply means that there is no opening of the skin, but there is still somewhat of a fracture. So you can see here, this is just a closed fracture on somebody's foot. There's no opening of the skin here, but you can see this nice clean line here, which signifies a fracture. A green stick fracture is one side is broken and the other side is sort of bent. And so the green stick fracture is something similar to what you would find in osteogenesis imperfecta, where we have one side of the bone that's not fractured, but it's significantly bowed, and then you're starting to see that fracture point here on the one side of the bone. So again, those green stick fractures are more common in osteogenesis imperfecta, or some other type of bone disease and disorder condition, those sorts of things. And last but not least, the comminuted fracture. The bone is broken, usually into many pieces. It's very ugly. You can see here that the bone is fractured into multiple pieces. There's multiple fragments. Oftentimes those can be very complicated to put back together and to heal, and those sorts of things. keep hitting the wrong button. This is an external fixator because it's on the external part of the body. And so what happens is there's still screws that go into place from the outside of the skin, and then they hold the bone in place. But again, it's on the external part of the body, and it's still fixating that bone so that that bone cannot move. Very interesting type of scenario. There's pros and cons to both of them. With the external fixator, which is here, you have less of an incision. You have more mobility with the toe, at the toes, at the ankle, at the knee, those sorts of things. So that can be a little bit easier to increase mobility right away. There are pin sites, so where these screws or pins are going into the bone. There's some wound management, wound care types of things to prevent infections, those sorts of things. But typically, the people that I've had external fixation on, they typically heal quickly. They're functional. However, it impacts their ability to get themselves dressed. Sometimes it can be very awkward lugging this heavy contraption around. Sometimes if they bump it, it can be very uncomfortable because those pins go directly into the bone. So there's that, right? With the internal fixation, right here, usually there's a pretty significant scar that the surgeon has to do. There's also various precautions that person has to do, particularly with hip ORIFs. There's typically toe touch weight bearing or non-weight bearing for so long, those particular kinds of components. And so either way, with internal or external fixation, you need to follow those surgical precautions, or there's those orthopedic surgeon precautions, those sorts of things. I worked with a little kiddo who had a bone growth issue. It was a congenital type of condition where his radius, and I believe it was just his radius, wasn't growing. And so they put an external fixator on his arm to sort of stimulate that bone to grow, and they were constantly putting pressure to apply on that radius. So a lot of times in OT, we were trying to have him use his hand functionally still with that external fixator on. We worked on dressing skills. How was he going to get a coat on or a shirt on with that external fixator? So a lot of times we had to modify some of his clothing so that he could continue to get dressed, those sorts of things. And we did a lot of wound care around the sites of the pins so that they wouldn't adhere down and scar down to those pin sites, because the skin would actually grow over those pin sites, and then that wouldn't be a good scenario either. So those are kind of the things that we did with external fixators when they were on the arm. Prognosis for fractures. They say that infants and young children simply take 2 to 4 weeks to heal. Again, those bones are very soft at that age and a little bit more pliable, so they don't take as long to heal. School-age children, they're saying, a fracture within 6 weeks. Adolescents, they sometimes say a fracture is between 8 to 10 weeks. Now, every physician, every orthopedic surgeon has different guidelines to follow, right? So they, I worked with an orthopedic surgeon who would constantly keep casts on for 8 to 10 weeks. And in therapy, we really struggled with that, because then when the cast would come off, there would be so much muscle deterioration or atrophy that we had to get back. A lot of times there was joint, like finger finger issues as far as joint pain and stiffness because they never were allowed to use their fingers while they had that cast on, or they couldn't use them to their full function. And so we had to really work on getting range of motion back, on grip strength back, and the rehab process was so lengthy. And the older the people were, we just had really hard we had really difficult times getting people back to 100% of function after they've been casted so long. You end up with short tissue or soft tissue shortening and joint pain and contractures and those sorts of things. Working with a different orthopedic surgeon, a lot of times it would be maybe immobilized for 4 weeks, and then for 2 weeks after that, they would have a splint that they could take off and do some passive range of motion with, very gentle passive range of motion. And then after 8 weeks, we could get them really going in rehab with the strengthening and those sorts of things because they were fully healed by then. So, and those are the clients that we really saw good therapeutic outcomes with. So anyway, those are my 2 cents, I guess, and fractures, and how they can be very rewarding to work with in therapy and see progress with. And I swear it all kind of depends on that orthopedic surgeon. And every orthopedic surgeon I ever worked with had a very interesting demeanor. And that's all I'm going to say about that. So moving on to scoliosis. I know scoliosis doesn't really aren't really associated with fractures, but it again fits with the uploading and stuff. But scoliosis is more of a deformity instead of a disease or a disorder, okay? Scoliosis is diagnosed if there is a curvature of the spine, more of that lateral curvature of the spine, that's 10 degrees or more. And so, again, with scoliosis, the definition is simply an abnormal curvature of the spine. And so these pictures are a little, maybe a little fuzzy on my end, even with the PowerPoint being blown up. But you can see here that this person is simply bent over at the waist. And you can see there's lateral curvature because if you look at the scapulas here, you can see one protruding out further than the other one. And so that would be a sign of some scoliosis, kind of a subtle sign. And just visually looking at somebody's back, okay, looking at their neck, their alignment, you can kind of see the shoulders a little bit higher, the scapula is a little bit higher, okay, so it's not very symmetrical with this one, and you can see the spine just kind of laterally, kind of going off to the side a little bit, and then coming back again this way, okay, so it's kind of that S shape. There's different types of scoliosis. One of them is a functional scoliosis, and this is where the individual is still flexible, and the spine is still flexible, and they can still move. And typically this functional scoliosis can be caused by just poor posture. Maybe they have a leg length discrepancy, and so even looking at that ASIS part of the hips and seeing if one leg is higher than the other. Sometimes the physical therapist will put maybe an orthotic in the shoe to kind of straighten that out because, again, that would affect the spine. Maybe they have poor core strength or postural tone. So they're constantly sitting in that posterior pelvic tilt and their shoulders are leaning forward. Hip contractures, maybe they have some kind of side pain or some other kind of abdominal pain, and so they're going to kind of affect their posture in that particular way as well. Congenital scoliosis, again, presents itself at birth since it's congenital, and there's usually some sort of structural component, an abnormal spine, some kind of spinal cord structure, some kind of deformity, something along those lines that's actually causing the scoliosis. There can be a neuromuscular type of scoliosis, and so if somebody has cerebral palsy, they're going to have different types of muscle tone. Okay, they may have very poor muscle tone in their core or their trunk, which causes them to lean to the side. And so, again, cerebral palsy is something that's neuromuscular in general. Osteogenesis imperfecta could also be neuromuscular it can also be a neuromuscular type. OP is osteopenia. And so osteopenia is just something related to the bones. So the bones aren't very strong, right? And so if you have like brittle bones or weak bones or bones with poor density, those sorts of things, it could lead to a change in that spine, for that matter, and affect your posture and the alignment of the spine. There's syndrome-related conditions such as Marfan syndrome, which is caused by very fast excessive growth, and so the bones don't grow symmetrically, they grow asymmetrically, and so if one side of the spine is growing and the other it isn't, you're going to have some sort of curvature of that spine. And then there's also idiopathic, which means that there's no known cause. It's just there. Here's a family picture of individuals with Marfan syndrome. So you can see that they're very tall and very thin. They have they're characterized as individuals who have very long arms. Okay, you can see this particular guy, this shoulder's higher than this shoulder. This hand is higher than this hand, or hiked higher than this hand. So that would be signs of the scoliosis that's occurring here. This young lady here is quite affected. You can see this shoulder is lower than this shoulder, which makes this arm appear longer than this arm, and so she would have a significant scoliosis as well. Marfan syndrome is also characterized by long fingers, spider-like bony fingers, as well as legs. And so when they stretch out their arms from one side of their body to the other side of their body, it's much greater than their overall height, and that's kind of a characteristic of Marfan syndrome. Idiopathic scoliosis, so kind of that scoliosis that doesn't have more of a cause, that actually constitutes 85% of all scoliosis cases. So a lot of times we don't know what causes scoliosis. In infants from age 0 to 3, it's very simply a 0.5%, so a very uncommon diagnosis you'll see, again, because with infants, their bones are still very soft and mobile, those sorts of things. As those bones start to harden, so 4 to 9 years of age, you have slightly more of an increase in scoliosis. Sure, certainly there's some growth that happens there, but adolescence is when it really takes off. Ages 11 through 17, and if we think about typical development of adolescence with boys and girls, there's puberty that's going on in that time. There's a huge growth that takes a part here, and so that adolescence is a big time where we're identifying scoliosis. And if we think back to maybe times we went to school, I know at least for us, when we entered the 5th or 6th grade or something like that, right before that, ages 11 through 17, a lot of times we'd have to take our shirts off in front of the school nurse and we'd have to bend over. and they'd look at our spine. And that's actually called the Adams Forward Bend Test. And so that's kind of that time when maybe those school nurses will be administering a test like that, the Adams Forward Bend Test. Scoliosis is actually more common in girls, in juvenile and adolescence. And ironically, that very small percent of 0.5% of infantile scoliosis, that's more common in boys. So, kind of interesting. Again, as we've talked about, when somebody has scoliosis, you may notice it at the shoulders. There's uneven shoulders, so one's higher than the other. If you look straight on at their back, one shoulder blade may stick out more than the other. If you continue to look down at their waist, one side of their hip may be higher than the other, or they may have that uneven waist. You may notice them kind of leaning to one side or the other, a lot of leaning. And people with scoliosis generally do have a lot of fatigue. Again, if you are constantly leaning to one side, you think of the oblique muscles, you think of all those muscles in your back, they're actually being in that shortened position. On the other side, they're being in that elongated position. And so that can lead to some muscle imbalance and overall fatigue. Here's just some pictures here of a young girl. You see different heights in her shoulders. So this one's sticking up a little bit higher than this one. This shoulder blade is popping out more than this one. You can kind of see it's a little bit lower too on this side. You see a hiked waist here, so this part is higher than this part, and so those are some simple signs that you can see somebody who has scoliosis. Girls, again, are more likely to have a progression of the curvature of the spine. The younger the age when the scoliosis appears, the greater chance that they're going to have a progression of that curve. So if you notice a scoliosis at a young age, the older they get, you're going to see a progression more than likely. The location of the scoliosis, the curves in the middle to lower spine are less likely to progress than those of the upper spine, kind of closer to the shoulders or between the shoulder blades. Spinal problems at birth. Again, so children born with that scoliosis have a greater risk of that progressive curvature getting worse as well. How they treat scoliosis, they can use some type of braces, which is going to hopefully prevent that curvature from getting worse. And so they recommend braces when the curve is 25 to 40 degrees and that child is still growing. So by, if the curvature of the spine, if there's curvature of the spine, they may make the brace to apply some pressure to that side or one side. And then the thought is, as that child grows, that growth will kind of correct itself because of the pressure that's being applied by the brace. So as a result, some of these braces are worn day and night. They can be removed for sports and other physical activities. And so some of the braces that are commonly used, they may be abbreviated TLSO for thoraco or thoracolumbo-sacral orthoses. So it's part of the thoracic part of the spine, the lumbar part of the spine, and even goes down to the sacral part of the spine. Okay, some of them fit underneath the arm and are considered low-profile braces because they don't go throughout the length of the body. And another one that's commonly seen is a Milwaukee brace, which you'll see kind of over here, which goes all the way up to the neck to all the way down to below the waist even. Unfortunately, sometimes people with scoliosis, a severe scoliosis where the curve is greater than 40 to 50 degrees, require surgery. And here, this is where surgeons may insert growing rods alongside of the spine, which are actual metal rods that they attach with screws and plates. And then as that child grows, those rods actually grow or extend with it. Um, some surgeons also do joint fusions, and so they may look at where those curvatures are starting, and they may actually surgically fuse those together so the curvature can't get worse. And with any surgery, there could be complications. And when you're dealing with surgeries that are close to the spine and close to the spinal cord, they can be very complicated and take a very long time to heal. So hospitalizations can actually last 5 to 7 days, and they can have activity restrictions for several months. So if you think about having growth rods inserted along your spine and spinal column, you're going to have incisions there, right? And your bones are going to have to heal. And so a lot of times they may avoid like twisting or bending or those kinds of things. And so if you think of OT's role, activities of daily living, dressing, those kinds of things can be can be affected. So again, here we're seeing some growth rods that have been surgically placed, and so you can see a very significant curvature of the spine here. And so they inserted these rods, and they anchored the rods down to parts along the spine. And so you can kind of see how, they went from this to more of this. And so you can see that it made a very significant effect in their posture. But again, with those rods in place, they're going to have a hard time bending. They're going to have a hard time twisting. And so our role, again, we may help them with activities of daily living, maybe post-surgical. In the hospital even, we may be going into their rooms and training them in dressing techniques, using adaptive equipment so they can get themselves dressed. We may be working on transfers, like how do you get out of bed? They're going to have to log roll. They're going to have to use their upper extremities to push themselves up instead of using their core. And maybe they will be in a wheelchair. So with significant scoliosis like these, I think of kiddos that have had CP, those kinds of conditions where they've been wheelchair bound anyways. And so you may be looking at changing their wheelchair positioning, seating system. You may look at, that functional mobility, ergonomics. You may be providing education on positioning or education on using adaptive equipment, and educating on use of braces even. And so here's a short video on a caregiver who is donning a low-profile scoliosis brace on their particular child. And so you may be working on educating people with scoliosis on how to don their own brace, as that's part of their activity of daily living. So a lot of potential here for individuals with scoliosis, with fractures, on how they would get OT services. Thank you.